an infectious disease specialist. My work is probably 90% hospital work, seeing patients in the hospital, and the rest office work. A lot of bread and butter infectious disease stuff, a little bit of HIV care, hepatitis care.
So I would like to start from the beginning, if you're okay with that. And I'm hoping you can tell me a little bit about maybe when you knew that you wanted to be a doctor, when you decided to go into medicine, and why? What got you interested in that?
Well, it was before I had any idea what I was doing. This was when I was growing up. It was from television. Two big shows back then, MASH and Quincy.
Okay.
And some people in the room may or may not have actually remembered those shows, but basically it seemed like a cool thing to do. My father is a doctor, but I don't know that really had a whole lot to do with it. He would take me to the hospital every once in a while. He worked as a pathologist. There wasn't a whole lot that he involved me in back then. Nobody tried to talk me out of it for a while. One of the things that's great about it is that, unlike some professions, not most, but maybe some, if you do your job well, everybody wins, as opposed to there being winners or losers. It's not a competitive industry. It's not one where I have to get somebody else to do badly for me to do well.
Right. Yeah. So as you grew older and continued this pursuit of medicine, was there a point, well, I don't know what the best way to articulate this is, but I'm curious how if your vision changed and when. So when you applied to medical school, or when you were in medical school, were you in contact that whole time with that same vision of this being a really good career to help people and being interesting? Did that vision change at all, or was it?
It didn't. It became more fleshed out in going through medical school experiences as I learned what the work was about. I had seen a little bit working in a hospital for a couple of years before medical school, and doing some volunteer work at that time as well. Some of those things, it seemed, what I pictured was seeing patients, hopefully doing a good job of taking care of them, learning what I needed to learn to do that, teaching, and that's something that it gets heavily emphasized as part of the process of becoming a doctor. You're exposed to teaching constantly, and your role models you're seeing are all teachers in addition to being physicians, even beyond the role of actually teaching patients.
Wow. Absolutely, that sounds like that's a big part of it. So now, where are you?
I am somewhat lost. There are a lot of things that haven't worked out the way I thought that they would, and I can go into as much detail as you would like about that. And it ended up with me seeing a career counselor last year and figuring out that I probably belong as an accountant rather than as a physician.
Really?
But it's one of those things where at this point it's a bit late to go back and undo that. So I'm trying to figure out how to change my career in a way that works out well enough for me without uprooting everything and risking everything.
Right. Can you give me an example of one of those things that didn't work out?
Well, I think I can describe it best by explaining sort of what I think, what I would still like medical practice to be for me and for everybody, and point out sort of how it often deviates from that. And I would say that my way is not necessarily the best way of doing things. If I see a way that I think is better, I try to adopt it if I can. And I think most of the things that have gone wrong actually still have a lot of good intention behind them. But I think there's a lot of arrogance in the medical profession, a lot of ignorance, a lot of self-interest that gets in the way of people doing what they probably maybe know is right or should know is right. The way I approach seeing patients, I start off with I was trained in an era when we had electronic records coming into our medical centers. So I was used to having a lot of information before somebody even shows up. Before I walk into a room, or before the patient walks into my exam room, I try to know everything I can from the available records. I try to confirm it with them. I'll go over with them their story about their illness, about the reason they're seeing me. And usually by the time they're seeing me, there's a pretty focused reason for it. It's rarely, I have no idea why you're here, because they've already seen at least one or two other doctors about it. So it's focused down. But eventually I try to get to everything. I try to go through their entire medical history, make sure it's right. Make sure that what's documented in the records is correct. Make sure I'm not missing anything. You'll have no idea. You would think people would not forget that they had their appendix out, but they do. They wouldn't that they had their spleen taken out.
Sure.
They will forget to mention it. They forget that they didn't already mention it to somebody. I try to make sure I've gone through all the relevant tests before I'm even seeing them. I try to do a good job examining them. Haven't learned that as well as I wish I did. Try to put things together in a way that makes sense, and try to make it make sense to them so they know what I'm thinking. There are a whole lot of phrases that I use and sentences that I use that come out exactly the same way every time, and one of them is, right after I'm done examining them, I'm going to clean my hands off, and then we're going to talk about what we know, what I think is going on, what we should or could be doing from this point. And we go through it. We make sure that they don't have any questions, that if they do, that I answer them, or I say, we don't know, but here's how we're going to figure that out. And try to give them an idea of what to expect. Move on and try to do a good documentation, whether that's in the hospital or in the office. I try to make sure that everything that came across in that interview, in that exam, and everything that's in my thinking is there in the record. So if I drop dead on my way out, somebody can pick up from where I left off and know what's going on. I try to move forward then, doing things the best way I can figure out to do them. My lack of knowledge often gets in the way, but I do the best I can with what I've got. If there's some particular piece of information that I really think I need to have to move on, I will look for it, whether that's asking somebody else involved in the patient's care, calling their pharmacy, contacting for outside records, looking up something on the web. There are so many resources we have now that we didn't have when I was starting. Back then we used to have to actually know how to use a medical library. What's that?
Yeah, that's terrifying.
How to find a journal on a shelf. And then at each subsequent visit, I try to make sure I filled in all the gaps of what's happened since I saw them, whether it was 24 hours or less, whether it's 3 weeks from then, whether it's from the hospital to the office, whether it's the office to the hospital. Try to make sure that I have all the right information, make sure that I know what's going on, and if the data are telling me something different, if the patient is telling me something different, if the tests are telling me something different, I need to make an adjustment, and I try to do that. I think that's, throwing a little bit of trying to save money where it's reasonable, where it doesn't put people at risk. If people are paying for their own care, throw in, well, we could do it this way, and here's about what it's going to cost you. We could do it this way. Here's the upside downside of that, and here's where it might save you some money, and which way would you prefer? And a little bit of that, and then going on. So that approach for my practice, and I will say that my practice is theoretically set up pretty well. There are 6 of us who are equal partners. We get paid the same. We share in the profits the same. Theoretically, we have the same workload. We finish the workday at about the same time, except if you're in office, you may stay later than everybody else. If your work's not done, we don't do that part. Theoretically, we all start at the same time. I start a couple hours earlier because the way I do things takes longer. The way I do things, I need a couple extra hours to catch up to everybody else, to feel like I'm contributing. But there are a lot of things that don't go the way I would like them to. I don't have the time I would like to be able to read, to be able to learn. By the time I'm done with taking care of my notes, taking care of my documentation, the notes I need to see patients in the hospital the next day, typically I'm spending 12 hours, 14 hours at it, and there's really nothing left at the end of the day for anything. I'm going to sleep and then getting up to start it all over again. And I see, there are a lot of people who don't do things the way that I do them, and I can't understand why. I can't understand why. If there's a fact available to you in the patient's record that might be relevant, why wouldn't you go looking for it? And the only thing I can understand is to save some time. Well, yeah, you're saving time, but what you're doing is important. And you know, it's in patient safety and hospital safety. That's one of the areas that I've been involved with in a lot of ways. And as medical director of infection control at 4 different hospitals in my career, it's something that I think about, and people, you can contrast it. It's often contrasted with the airline industry, which for a while had an abysmal safety record and has done an amazing job. And they have a very different way of doing things. And there's an interesting question asked of airline pilots and asked of surgeons. And they pick surgeons because it's kind of close enough to procedures that you might see in the airline industry. And they asked pilots, if somebody you're working with sees you're about to make a mistake, do you want them to tell you? They all say yes. Every last one of them. If you ask surgeons, 60% of them said no. Wow. And one big difference between an airline pilot and a surgeon is if the plane crashes, the pilot dies too. But I think it goes a little bit deeper in that I don't think it registered with the surgeons what they were really being asked. Yeah. It's if somebody thinks you're making a mistake. Well, of course I'm not making a mistake. I want you to keep your mouth shut. And I've seen it play out. I've seen it play out in missed instruments in patients after surgery because somebody didn't want to wait for an instrument count or didn't believe the instrument count was wrong. I know I took everything out. And these are people who care about their patients. They want them to get better, but it does not occur to them that there could have been a mistake. But I think people also tend to, they don't realize how easy it is to make mistakes, how easy it is to miss things if you don't do things methodically. One of the best teachers I had, George Condos, a cardiologist, used to say, do it the same way, every time. It's how you avoid making mistakes. He was referring to the cardiovascular exam, which I still don't do nearly well enough, but it applies to just about everything in medicine, that checking, double checking, you know, making sure you're not missing something, making sure you're not leaving out something the patient has to say. A sentence that I almost always say, is there anything else that you think I need to know about you right now? Is there anything else you wanted to ask me? And a lot of times patients have no idea what they might say, but every once in a while there's that thing that was nagging at them, or, you know, I forgot to mention such and such. Forgot to mention I have a pacemaker. Oh, really? That's interesting. That's important. And so I see people cutting corners, and when you do it routinely, you may not necessarily see the harm it does, because if you've never looked at a report, how do you know what was in that report that you could have found useful for that patient? I tend to see it because I tend to look back, and in my field there are a lot of things I can tell just from looking at laboratory tests that I can tell, you know, nobody really looked at this. And you know, it gets a little frustrating because I see other people, in, not just in my line of work, but in all specialties, moving way faster than I think is safe. They're getting patients seen. I went in and see a patient. I spent 25 minutes in with her. I walk out, her primary care physician walks in and spends 2 minutes out, comes out and is dictating his history and physical. I'm thinking, how on earth did you do that? And part of how he did it is he opens the chart, looks at the nurse's history sheet, and dictates directly from that. And I know at least some people think my way is a good way of doing it, because I've had people remark on how complete my histories are.
Absolutely.
And the thing that springs to my mind is, and I never asked this, but am I going to see you doing it that way? Because you shouldn't look at it and say, that's a great way to do it, but I'm going to keep doing it my old way.
Right.
It doesn't make sense to me. And I know there are pressures of time, there are pressures of money, but it ends up costing time. It's easier to do it, if the old saying goes, if you don't have time to do it right, how are you going to find time to do it over? I know what I've asked, I know what I've checked, I know that I don't need to go back over the old territory once I've gone over it. But it's very frustrating when I see a patient who asks me, so how's my liver? I had no idea I had a liver problem. I look up his labs and yeah, there's a little abnormality there. And then I say, well, I'm going to take a look at what it was before. So I look at the previous admissions, and it's a few mouse clicks on the computer system. This is not difficult to do. It's not complicated to do. It's something that takes literally 20 seconds. When we found out that he had hepatitis C diagnosed by testing about 2 years ago, nobody ever told him. Nobody ever followed up on him. So in a routine follow-up visit, I get to have the conversation, okay, did anybody ever tell you you had hepatitis C? So now I have to not only manage I'm telling a patient about hepatitis C for the first time and what needs to happen, what to expect, but also try to manage the fact that he has just gotten a shock and is wondering, why on earth didn't anybody tell me this before if they knew it before? So I have to manage a huge trust issue, and this is the first time I've ever met this person. I have somebody where they're admitted for a pneumonia and people are trying to figure out what's going on, and I mentioned to the lung specialist saying, and by that you did know he has HIV, right? No, in old testing, but nobody bothered to look at the old testing. And this patient knew he had it, but had a psychiatric disease that he seemed to think he was cured. I asked him, so why are you off your meds? Well, they said my HIV was gone, so I didn't think I needed them anymore. And you have no idea. If you rely on the patient, you have to listen to them. You have to take what they say very seriously. Assume they are intelligent and informed, and then assume that they may have missed something, just like any intelligent, informed person could have missed something. When you see it over and over again, it gets very frustrating. I'm spending a lot of time trying to do things the right way. I try to talk to people about the right way of doing things. If I see one of my colleagues doing something in a way that I don't think is the best way to do it, I'll ask them about it. I try to give them the chance to tell me, why they're doing it their way. Often they'll agree with me, and then they keep doing it their way. They'll agree that what they're doing is wrong, and then they'll go back to doing it. And I don't like to think that they're stupid enough to have forgotten the conversation. I like to think that they're smarter than that. One of the things that you're going to run into in medical training is the concept of supervision. And supervision, in most people's minds, if I were to say, I'm going to supervise you in your performance of this procedure, in your performance of this history, taking a history, doing a physical examination, your management of the case. You probably get the idea, and it's an idea that Medicare and CMS services shares, that I'm going to be in the room with you when you're doing these things, that I'm going to be paying attention to what you're doing, and if there's something missing, I'm going to supplement. You'll find that as often as not, does not happen. Another way to supervise that I think is reasonable, and this is what I used to do when I was teaching medicine, was that I would sneak around and see the patients before rounds 2, so I had a clue as to what was going on. I would look up the data, look up the labs, and so if somebody's presenting me a case and they missed something, I knew it. I had it. So I could point it out, and they're in training. It's understandable. If they could do it as well as a practicing physician, they didn't need to be there. So it was never, shame on you, you missed this. I'm angry at you, you missed this. It's, by the way, so I was talking to the patient, they also mentioned such, and here's why that's important for this particular case. I would do my own documentation. I never did was present and agree with above progress note, which a lot of folks would do. But I'd see people who were good physicians. They were the people who trained me, who would overlook things, and sometimes bad things happened because somebody else didn't double check the labs. They relied on somebody else to do it. Going into private practice, the same thing happens. And it seems like people tend to value their own time more than they value their patient's time or health sometimes. And there are lots of dedicated docs. They'll stay late to do that operation that needs to be done, and it's wonderful. They will take the time to comfort a patient when they need to be comforted. They'll take the time to talk to them about things. But you'd think that that should be all the time. I know how fast they see patients. And they're very nice people, and they really want to do a good job. They feel a pressure to do things faster. Maybe they were rewarded for that sort of behavior before. And there is sort of and I will tell you, I get a little bit of a boost when I see that I've come in earlier than everybody else and managed to see more patients than everybody else. But I check every patient the same way, whether I have something I have to do in the afternoon and have to get out quickly enough, whether I have nothing else to do, whether I need to learn a lot of patients for the upcoming weekend call, whether I have nothing else is pressing on me, I'm going to look over all the antibiotics. I think I should know when they stopped and started them.
Right.
I'm going to look at the cultures. If the ID doc doesn't check the cultures, who's going to? Or who's going to interpret them properly? That's my job. Likewise, I would think that a cardiologist should know if the device implanted in their patient is a pacemaker or a defibrillator, and why it's there. And it frustrates me when I know that, and that's in my history, and it's not in the cardiology consultant's note.
Yeah. Absolutely.
So, I see myself spending hours and hours doing what I think is the best that I can do with what I have and what I am. I don't see everybody else's oars in the water in the same way. And they almost don't see that there's anything wrong with it. And one of the attitudes that you'll find, and one of the reasons why you'll find a lot of resistance to change in medical practice, there are people who are unhappy about their practice and will speak up. There are people who are unhappy about it and won't say a thing. And there are people who genuinely think medicine is great, and I'm great at it, and this has been wonderful, and everything is fine. And there are lots of people who are more than willing to tell us that. It would be wonderful if every patient knew if their doctor was doing a good job or not and fed that back, but the fact is that patients can love a doctor who's terrible. Speak their language, if English isn't their primary language, speak their language and they're yours until you do something really bad to lose them. Seem confident. Patients often like that. Give definite answers, even if the answer's wrong, and you'll get a certain following. It may not be the right thing to do. I'd much rather tell somebody, I don't know what you have. Here's how I can figure it out. And if I'm at the end of how I can figure it out, here's where I'm going to send you to get this figured out. And I would much rather send somebody somewhere else. I don't care who makes them better as long as they get better. And if you find out what you had, let me know, because I don't want to miss it another time. It's perfectly fine to do that. But there's a whole lot of everything's right. And there are lots of people telling us we're great guys. Pharmaceutical reps will always tell you, you're doing a good job. You know a lot. You know about these drugs. They'll make it sound like they're not selling you something, but they are. The malpractice carriers, they try to train us not to get sued. They try to train us to do things to be defendable in court. But the amazing thing is that they will also tell us, hey, you guys are doing a good job. You are the experts. My malpractice carrier puts out these newsletters every once in a while, and every once in a while there's a case where they talk about a successful defense. And if any physician who hears this story should look at this and cringe. A 70-year-old man comes in with headaches that he's never had before. Red flag. 70-year-old men do not come in with brand new headaches to the doctor unless there's something really wrong. 70-year-old men don't come into the doctor when there's something really wrong. This is the person who's going to sit at home with chest pain till he gets his ride. And he's telling his doctor, I'm having these headaches. Patient gets all kinds of medications, some narcotics, benzodiazepines. You don't sedate elderly people without a darn good reason for it. And you don't give benzodiazepines to treat a headache unless you want the patient just to shut up. You end up having temporal arteritis. And if you were taking your internal medicine board exam, this elderly person coming with a headache that he's never had before, that's one of the things they expect you to find. And they present the case in a way that makes it sound like when this guy lost vision in one of his eyes because this diagnosis was missed, that it was perfectly understandable to not have looked into it further. And so it's no wonder that physicians often think, we think we're better than we are because we have a whole cheering section telling us that. Because the malpractice carrier wants us to like them because they want our business. And it's much easier to get a doctor to do things the way you want them to if you convince them that they're wonderful first, then convince them that it was their idea in the second place.
Wow. Well, it sounds like, I mean, there's, from what I'm hearing from you, that there's kind of been this sense of being let down by your own profession or by the people around you. I mean, from what I gather, you have an extremely comprehensive and talented and thorough way of approaching medicine and dealing with diagnoses and patients, and an immense amount of respect for the process, which sounds like it's something that other people don't value as much in that field. Maybe that's changed more recently, or maybe it's always been that way. But I'm curious now what your ideal vision of medicine is, and either as a whole or your personal practice, what it is that you really, given what you know now and kind of this incredible path that you've walked in medicine, where you see things going ideally, if you could redesign this process.
I think everybody would learn medicine well, and that's one of my big regrets from medical school, is not learning things better. Everyone would try very hard to do things the right way and consistently. It's amazing how much time you can actually save by doing things the right way in the first place, as long as everybody else is doing it too. If every doctor is thorough enough with their patients and gives their patients time to talk, you don't have this bottled up genie problem where as soon as you uncork that bottle, all kinds of things are going to come out, because if you're the first person, you shouldn't. It's strange when I ask simple questions and patients tell me, you're the first person who's asked me that. And they want to tell me about everything. I never look at my watch in the office while I'm with a patient. It doesn't help. You can't hurry things along. They'll come out somewhere else. They'll come out some other time. And if the first visit is an hour when you budgeted 20 minutes, that's okay, because the next visit will be shorter. You can do a 5-minute visit with a patient when you already have all the information and they trust you and trust that you're not going to shove them out the door. I think we try to do too much. I think there is no good way to see 50 patients in a day in the hospital. Sometimes I have to, and there's 60 patients, and there are times when somebody's not going to get seen. That's something I've only started doing this year, when I realized, it's 16 hours, there are 8 follow-up patients, I'm hoping they're on the right stuff. I'm going to look at their records at home on the computer, but I need to go home and get ready for the next day. If we had more people doing, in some ways we need to do less. If you already know that somebody's had that CAT scan done, you don't need to repeat it. There's no reason somebody should have 5 positive hepatitis C antibody tests because nobody looked at the 4 previous positives. Once you've had it, you've had it. That test does not help you any further. You don't need to prescribe at every visit. You don't need to change something every time we see patients. There's an interesting relationship in consulting in medical practice. You have primary care physicians and other physicians who will order consults, and the consultant who has to respond to that. We have 2 customers. We have the doctor who consulted us and the patient. Hopefully we'll put the patient first, but there's always this little bit of, I don't want to offend the referring physician. On the other hand, there's also, I don't want the doc who referred to me to think I'm useless, so I have to do something. I have to change something. I've actually had a primary care doctor say, if I consult you on a case and you don't change something, I'm not consulting you again because I don't need you. Well, maybe some of the times you're going to get it right. And then you're going to learn maybe you don't need me for this. And maybe you'll call me only when you do need me, and that's perfectly fine. I'm okay with saying they're on a reasonable antibiotic approach, the right tests were ordered, we're going to see how things play out, and see how things go. I would love medical practice to be more permissive of being wrong and accepting that we're going to be wrong, accepting when we are wrong, and encouraging people to tell us when we're wrong. I remember shocking a nurse on the floor when we have a patient who's on the obstetrics unit. She has this terrible headache and some respiratory symptoms. She's pregnant, and her neck is stiff. I'm thinking she has meningitis. We get her on treatment, we get her off the unit, because nobody wants a meningitis case on the obstetrics unit. We get the spinal tap arranged, which is no mean feat in somebody who can't bend forward. And we get things arranged, and we have testing all in orders tucked away, and the nurse asks me if I think the patient has meningitis, and I think yes, I think she probably does. So the next day I'm seeing the patient, the spinal tap was thankfully negative. It's wonderful. She had sinusitis and not a meningitis, and that was great. And he said, yeah, yesterday you said she had meningitis. Oh, I was wrong. he was shocked. He appreciated that I said that, that I didn't make up a song and dance about how the tests were wrong or how this and that, or no, I didn't say that. You know, we have to be able to say that because we're all going to be wrong. Even the best docs are wrong some of the time. If you're always right, you're only answering easy questions. And there's not enough of that. There's not enough of, I'm open to the possibility that I'm wrong. Because sometimes I'm going to tell people, you know, you thought it was this, I think it's that. I thought it was this yesterday, I think it's that today, and I might think it's something else in 2 days. And if we don't change what we do, we're going to do a disservice to our patients. And I'm sure patients would much rather hear, yeah, I think you have meningitis today, tomorrow, thank goodness you don't. I'm glad I was wrong. Than an excuse as to why it wasn't. The flip side of that, I'm seeing a patient who comes in to the hospital with a headache. It's going on for a while. She had been admitted elsewhere, seen an infectious disease specialist, got some antibiotics, no diagnosis reached. When she was in the hospital, she tells me that she asked for a spinal tap because she thought she might have meningitis. No, no, you don't have meningitis. She goes home. She comes back to the ER. They call the infectious disease consultant. Her headache's worse and she's vomiting. Give her some anti-nausea medicines and some fluids. She doesn't need to be admitted. Send her home. So she shows up at our hospital. Gee, it sounds like you have meningitis. We did a spinal tap, and she did. Fortunately, she did perfectly fine. I asked her, would you like me to send a letter to the doctor who saw you there, explaining just what happened to you? Just kind of not a, you were wrong, but you know, I saw this patient so-and-so in the hospital. I understand you had seen her previously. Here's what we found, and here's how we treated her. In a way that was not scolding, but you know, again, if you never get that feedback. I would love a medical system in which we had, you know, and had emails where we could just send back and forth to each other. I'm seeing your patient, and here's why I think you got such and such wrong. And so when I get that, great, I know something. I was wrong yesterday. I'm a better doc today for knowing that I was wrong. That is part of how we learn, how we grow. I would love to be able to do that, but I don't know who I can tell is wrong and who's going to get offended. We have, unfortunately, large egos, and of course it would be great if all these other things would work themselves out, malpractice, insurance, money. It would be great if that, but that's a relatively small part, I think, of what's wrong. And if we were all working together to do things exactly the right way every time, malpractice would go away. People wouldn't sue docs who try their best. They don't sue docs who try their best, make it clear they're trying their best, and only make honest mistakes. They sue docs who clearly drop the ball. And there are a lot of them out there who will drop the ball.
So from, you know, with that, knowing what you wish you could change, and having an opportunity to reflect and be here doing this workshop, how do you feel like you're going to go home? And what do you feel like you might directly take away from this that you can really use as a tool to change your practice, to work towards that vision that you have?
I don't really know yet, because not being a primary care physician, I'm still dependent on those people who consult me, doing things certain ways. It's a bit hard to identify those populations and do things in the, you know, one thing I do take away from it is that it is possible to do things your way. Sometimes you're going to have sacrifices. There are things that can be done better. I've learned things that our practice might be able to do better. Whether we will or not depends on whether I can convince my partners what to look for in a setting. And at some point, if I ever de-differentiate back to general internal medicine, maybe I will do some sort of primary care adventure or something with HIV practice as an outpatient. It's a scary thing to think about doing things that you're not sure you can do.
Why is it scary?
Well, the idea of going off into a new business venture that you're running. I've never run a business, and I've made a lot of very bad decisions in my life. So I don't really have a lot of confidence in the decisions I've made. It's also, of course, worried about providing for my wife, providing for my future, wondering what's going to happen if I leave, where will I end up? You know, their practice is much worse than mine for people that say, you will see this number of patients, you will do things this way, you will do things our way. You know, as long as they let me set my hours to some degree when I start, I can sort of do things my way and not get into any real trouble with the practice I'm in. So it's sort of, am I jumping out of the frying pan into the fire? You know, there's a term that my therapist introduced me to, which is failing up, trying to always do that thing that's more difficult than you think you can do. And even if you fail, you're going to learn things. And it's a great idea.
I like that.
I don't know that I have the courage to do it.
Yeah, that definitely sounds like it takes a lot of courage. So if you could do anything differently, would you? If you could have done anything differently in the past?
Other than going into, I think the places where I would have, the things I would have done differently, I would have become an accountant if I knew then what I know now. Believe me, I could. And if it were just a 6 months correspondence course, that's what I would do.
You sound like such a great doctor, though. I feel like we would have missed, you know, all of the patients that you've been honored to treat and, you know, had in your care. But I mean, that's your decision. I honor that. But
I think I would have done a better job in medical school of learning things, paid more attention. I almost flunked out my first year, so that wasn't a good start. I think I might have looked harder to do outpatient general medicine with some HIV work rather than going into just infectious diseases after my fellowship. I think it's easier to maintain some control. You know, I would love to be able to say, cut my salary in half, cut my work hours in half to match, and I could do a lot better. Cut my salary to a third and my work hours in half. That would be an okay arrangement for me. You know, I make far more than I deserve, and I can get by on a lot less. But it's just really hard to do that when you don't do it right from the start. And nobody teaches you these things when you're in training. You see lots of people who are happy, lots of people anticipate they're going to be happy, and lots of people who are pretending to be happy. You know, there's always this, I'm waiting for that next milestone. You know, when I get through medical school, it'll be better. When I get through my residency, it'll be better. And in some ways, some things are. But then there's that huge, once the buck stops with you, you know, there's an interesting phenomenon that happens in medical training. Medical training is not like training for a lot of other things, in that, you know, how do you know you've got the right answer when you have an electrical project? Well, if you don't see sparks flying and things turn on, you probably got it right. You know, if you're cooking and it comes out blackened and that was not the intent, you did something wrong. In medicine, often how you know you're wrong is that somebody who's supposed to know better tells you you're wrong. So when you're a medical student, if the intern tells you you're wrong until the resident tells you that you were right. Or and everybody's looking to the attending physician to tell them what's wrong and what's right. You finish your training and suddenly you're the one who's deciding what's wrong and what's right, and you don't have a backstop. So if you didn't learn it really well and don't have that good capacity for self-doubt, you have a whole lot of room to say, this is what they have. And if you never question it, you can be wrong. And one of the things that they'll tell you, I first heard it as it's hard to kill a vet, because my first medical rotation was internal medicine inpatient at the VA hospital. But it's kind of hard to kill a patient. You know, the human body can take a lot. A lot of things will heal themselves if given enough time. And if you give treatment that addresses some of the symptoms and just let the body heal, you'll get away with it a lot of the time. Or sometimes things will become obvious soon enough and you can recover without ever admitting that you made a mistake. But it lends itself to this complacency. I did such and such, I said they had such and such and they survived. I must have been right. You know, it's a bit like playing the lottery and never checking the results. Right. Yeah, I think these were the winning numbers. Sometimes you're going to be right, sometimes you're going to be wrong. If you don't check, you don't know. And it's that scary precipice, and either you're going to be really together and know how to make it work for you in a conscientious way. You're going to be really conscientious and drive yourself nuts. You're going to do things the wrong way or some of the wrong ways, even with very good intentions. You're going to see other people doing it. You're going to follow along. And it may be satisfying for a while, but eventually you may run into things that tell you, hey, you know, have I done this? Have I been doing things wrong the whole time? Am I contributing more to the problem? And even if you don't know why, you know, patients will be frustrated. Patients have a way of expressing things. They'll express it in symptoms. They'll express it in their words. And if people leave your office angrier than when they came in, there's a problem. Often you'll know it from your receptionist if your receptionist talks to you. I am really thankful to have the staff that I have, because they will sometimes tell me, you know, I get behind. People are angry. My appointment was 45 minutes ago. Fortunately, I get to hear from my receptionist, they're never angry when they leave. I talk to housekeeping in the hospital. They're people, and they're surprised sometimes. It's amazing. Talk to nurses, give them respect. Give the technologist respect. Know that they know they may know what they're doing, and they may know something you don't. There is not a single, you know, if you do it with respect, give respect, get respect, and you'll learn a lot of what you're doing wrong and be able to correct it. If nobody feels like they can talk to you, and there are some doctors who are like that. There are some doctors who don't want to answer a page. I remember I was going to call somebody who was just on the floor 10 minutes before. I tried to have him paged, and the nurse told me, he's not going to answer you. And darn, she was right. And he's a nice guy. It seems to be. But you have, you know, there are ways of doing it where you'll get better and better over time. There are ways of doing it where you'll drown. And there are ways you can do it with blinders on and never know what you're missing, but you'll probably know you're missing something. And it may not show up in a patient satisfaction score. It may not show up in a test result. It may not show up in what the hospital says about you. It may not show up in awards. But somewhere, I'd like to think it'll show up. And if I'm wrong, don't tell me.
True to your word. Well, that's an enormous, I'm like personally gleaning a lot of advice, you know, as you're talking. As somebody who's going to be applying to med school, I'm hearing a lot of really, really valuable advice from you, so thank you. But is there anything else that you would advise those going into medicine as it is today?
I think it is a great idea to have a very clear idea of some things that you really would want to do. When I was starting my training, at first I thought I was going to be a neurologist, because I worked in a clinical neurophysiology lab for 2 years, and it seemed interesting. The brain was interesting. That expanded to include internal medicine, ENT, at one point even general surgery, and thank goodness I didn't go into that. Psychiatry, until I got a really bad evaluation in my psychiatry rotation. But knowing that there's at least something out there that you have some firsthand knowledge of what it's like. whether that's tagging along with somebody through their office, through their hospital practice, seeing a bunch of things, volunteering, getting to know something. So you know, when I'm done with this, even if nothing else strikes me as being interesting, drawing me to it, I know that there's that thing that I think I would love to do and can do it my way. Because you know, you go in not knowing, and that's easy to do.
Right.
You go in thinking you're going to be drawn to something, and a lot of times you're drawn to what you think you can do, what you think you'll get into. You know, this residency is too competitive, I'm not going to get into that. You sometimes try to see who's happy, which will scare you away from surgeons sometimes.
Right.
You try to, but who's happy in your training program is not necessarily who's happy elsewhere. You tend to see things differently in training than you'll see in private practice, and some for better, some for worse. And if you don't have that something that I know, I'm pretty sure I can be happy being a family doc, being a head and neck doc, being a psychiatrist, something, knowing the good and the bad about it, knowing the business of it, knowing something about where it's headed. And the other thing is, most people tend to be way overly pessimistic or optimistic about what they're doing in particular. My father told me that he would not pay for medical school if I tried to become a pathologist.
Which he was, right?
He was. Okay. He thought there wouldn't be a need for it. He thought that, and there's been an explosion in molecular technology to keep them playing for decades to come. You never know who's going to have business. The radiologists are taking stuff from the surgeons are taking stuff from the GI guys. Everybody's taking from everybody else, and eventually it kind of evens out. Nobody, even the best experts, don't know what's going to happen. One of my favorite stories, I was taking an epidemiology course given by the CDC, and one of the presenters, one of the big guys at the CDC, and he was at the CDC back in the early 1980s, and he was given the opportunity to investigate some weird cases of pneumonia in California in 1981. This is not going to turn out to be anything. And of course, it turned out to have been the biggest thing in infectious diseases. And the only thing that's more remarkable than the fact that he was wrong about that, despite the fact that he was a real expert, is that he's willing to tell that story. That he basically opted out of early HIV ground floor. And so anybody, no matter how much they know, can be wrong. So don't let one person talk you out of anything, including me.
Yeah. Well, thank you.
You are welcome.
Is there anything that I didn't ask that you wish I had asked, or that you would like to tell me?
There's something that a lot of us think when we go in, and I will tell you it is categorically untrue. Unless you love practicing medicine so much that you would do it for free, make sure that there are other things in your life and that you make time for them, because it is so easy to let medicine take over every aspect of your life, every bit of energy that you have. And you may be the kind of person who says, you know, I'm not going to miss this and that. But eventually, you'll always look back and think, there are things that I missed. You can't be, I think, a really good doctor without being a whole person. You're dealing with people all the time. You have to have ways of recharging. You have to have ways of separating yourself from it. You can't carry everybody's wounds with you. You can't cry for everybody all the time. And you can't spend everything you have expecting that you're going to get paid back by the profession, because you might not. And if it's all you know, if it's all you have, it's kind of a miserable life.
Well, thank you.
It's a pleasure.
Likewise.